Okay, good afternoon, everyone. This is Change Grow Live's pop-up session in Birmingham. Today we have Jackie and Martin from the Hepatitis C Elimination Programme to talk to you about hepatitis C in Birmingham. So it's over to you.
Hi everyone, my name's Jackie Webley. I'm a project manager within the Hepatitis C Elimination team.
Thanks, Jackie. Hi everyone. So my name's Martin Hull. I'm a GP in Birmingham. I'm also one of the local hepatitis C GP champions involved in this project. And then in addition to that, I have a role for an organisation called Turning Point. What we're going to do today is talk a little bit about hepatitis C, a little bit about the options available to Hep C at the moment, Hep C treatment, and then a bit about the programme that we're involved in terms of working on identifying cases and referring cases of Hep C and what you can do in primary care. So if I can get the slides to work. Oh, there we are. Good. I didn't go past one then, did I? No, I don't think I did. Okay, so hepatitis C, you'll all, as GPs, know a lot about Hep C anyway, but just to go over where we are at the moment in terms because of the nature of the virus and how it's transmitted, does disproportionately affect marginalised groups, including people who inject drugs. That being one significant area of risk for hepatitis C. There are a number of others, again related to its rate of transmission, which we'll touch on. And the thing about hepatitis C that makes it different to, for example, hepatitis B, is it's pretty much always asymptomatic when first transmitted. So people don't know that they've got it, and inevitably, eventually, will tend to lead to either hepatocellular carcinoma or to liver cirrhosis, or sometimes both. Can take a long time to do that, but we'll eventually get there. So it's a disease that needs to be identified in people who aren't presenting with symptoms, and so needs to be screened for in order to identify it. And if not picked up, it will inevitably eventually lead to very serious liver disease. And the reason this has become more, I guess, pertinent of late is that the treatment for hepatitis C has significantly, really significantly improved in the last 5 to 10 years. And we've now switched over from the previous regimes, which were usually interferon-based, 12 months of treatment, lots of side effects, and a fairly middling to average cure rate, to the situation that we're at now with the newer oral regimes of direct-acting antivirals, where significantly above 95% of people will be cured with a pretty short course of very well-tolerated oral tablets with minimal rare side effects. And so there's been driven nationally through NHS England, and in fact internationally through the WHO and a few other groups, a real push for us to treat those people that we know have hepatitis C already, and also to try and identify the cohort of people who have hepatitis C and who don't know that they've got it, so we can then offer treatment to those people with the probably ambitious but not completely unrealistic target of the complete elimination of the disease of hepatitis C. And this piece of work has been going for a while with a lot of kind of ring-fenced allocated money provided central government. And in the last 10 years, 90,000 people have been treated for hepatitis C, and there has been a resultant significant reduction in prevalence, so a 61% reduction in prevalence of the disease, and also, and again, really significantly, a significant reduction in death related to Hep C, and a really significant reduction in hepatitis C related liver transplants. So already big strides in terms of the incidence and prevalence of the disease and treatment outcomes, and which is kind of why the next step from, I guess, the national policymakers in the field is to really work on trying to identify those people who either there is knowledge that they have it or it's known that they have had the disease, and also those people who haven't got the disease to find out whether they do have it, and then obviously get people into treatment. So we think now, and this data is taken by kind of modelling, by statistical modelling on the number of people thought to have hepatitis C that don't necessarily know that they have it in most cases. So a number of those people are people who inject drugs, so currently injecting drugs, or certainly currently in drug treatment. And drug treatment providers like CGL, who Chloe works for, like Turning Point, who I work for, are, I think it's fair to say, better at testing people who for bloodborne viruses, and that's been enhanced by things like having dry blood spot testing. And so I think that that's an area which has really performed significantly better over the last few years, but there are still some people who are slipping through the net in drug treatment providers, and who also will have GPs as well, who may not yet know they've got Hep C, or may have had a diagnosis of Hep C and not yet been treated. And obviously, by the nature of injecting drug use, some of those patients are fairly vulnerable and fairly chaotic in terms of attending treatment, and may need assistance to getting either tested and or treated. So there's a significant cohort there of people who are drug users. Now, there's a larger cohort, it's thought, of people who have a history of injecting drug use in the past. So it's estimated around about 40,000 people. So these are people who are not currently in contact with drug treatment providers. So they're either past users, or in fact, I guess there are also, I'm not sure which cohort this would fit into, there are people who are currently injecting drugs who aren't in access or in contact with drug treatment. But again, in most cases also of whom have a GP. So it's a pretty large cohort of people who are either current or previous drug injectors who have Hep C and who may or may not know about it, but who haven't had it treated if they do know about it. And then there's a smaller cohort, but again, a not insignificant cohort of people who have contracted hepatitis C through other means. A lot of those are people who've moved to the UK already having contracted hepatitis C from countries where there may be higher prevalence. People who may have had medical or dental treatments abroad, where there's a higher prevalence often. A small cohort probably of people in the UK who may have contracted Hep C through historical blood products. Most of those would have been picked up, but again, it may be people who had transfusions or blood products in other countries where screening was not as accurate as it may be here now. And then a smaller cohort of people who may have contracted it through sexual transmission or through vertical transmission, so from mum at birth. So still 60, 70,000 people probably around in the UK who've got Hep C, who either don't know that they've got Hep C, or certainly if they do know about it, it's not known about in terms of specialist treatment hepatologists, and they haven't had treatment for it. So that's an area of which we need to concentrate on at the moment. So we look at that locally in terms of what that means for GPs in the West Midlands. It's estimated that about 1 in 500 people in the West Midlands GP surgery will have a code on their records of being hepatitis C positive. Now, that's obviously going to vary depending on the demographics of a surgery. So if you have a higher prevalence of injecting drug users, if you're in an area of deprivation, and or if you're in an area where there are higher numbers of people who've moved to the UK from an area where there is a higher prevalence of hepatitis C, then the numbers will be higher. And so one of the things that we're trying to do, along with NHS England nationally, is to find out a little bit more about the data about both people who have already got a code of hepatitis C positive, be they have whether they be treated in the past or not, and also people who may have some of the risk factors that might mean they're at risk of hepatitis C. And so when we talk about in a minute about the search that we're asking people to look at for us on their practice, one of the things is looking at both the current prevalences and the current risk factors for people who may have hepatitis C. And we think that 2% or more of patients in Birmingham will have 3 of those risk factors. Those risk factors are a variety of things, including where you're born, like I said, drug use. If you've been in prison, there's a number of different things that are pulled out as risk factors. And about 11% of people in the UK thought to be born in countries where Hep C has a higher prevalence. And so that's a little bit about what the search will do. And then the other thing about the search, so it gives us, I guess, a more accurate feel for the data. And then there's things that we may decide to do now or even a little bit further down the line. But the second thing, and the thing that we're really asking practices to do at the moment in terms of that search, is to have a look at the people who already have a code on their records as having hepatitis C in the past. And this search, I'll talk a little bit about the search in a second, but the reason that we want to concentrate on that, this feels to us like a bit of an easy win in terms of the fact that there will be, so when the practices run these searches, they'll identify a number of patients who have a code of being Hep C positive, and what we can do then with that list of patients is we can double check them versus hepatology records and see if they've been treated, if they completed treatment, if treatment was successful, or indeed if they've not been referred to hepatology at all in the past. And we can then come back to the practices with that information, and you and the practices can then have a look at those small number of patients to see if there's any work that can be done, or indeed if there are any people who do seem to have a diagnosis of hepatitis C that haven't been referred and that would obviously significantly benefit from being referred now and having access to that over 99% cure rate, minimal side effect oral treatment that probably wasn't available when they may have been diagnosed with Hep C in the past. So that's a kind of piece of work which we're right in the middle of at the moment. And we've asked practices across Birmingham to run this search for a while now. We've had quite a large number of practices get back to us having done the search and having been provided with the relatively short list of people who have a code of Hep C, cross-referenced it against hepatology records, and then come back to practices to either confirm, yes, this person has been treated and should have a hepatitis C resolved code attached to their records, which would take them off lists. Or for some people, we've said they may need a blood test to find out whether they've successfully been treated, because they may have done partial treatment or they may have completed treatment but not had a blood test afterwards. So just to kind of close the loop for that patient. And then for a number of patients that they're not known to hepatology, and those patients would need to have their notes looked at to see where that code was put on, to make sure that code was accurate. And in some cases, to either do a confirmatory blood test now to see if they are hepatitis C positive, and or to refer them to hepatology for review and for treatment. And that small piece of work then has the potential, obviously, of being life-saving intervention, actually, because if we do have patients out there that are so identified as being Hep C positive and having had Hep C for probably quite a long time now, they are cooking up their liver towards either liver damage, cirrhosis, or hepatocellular carcinoma. And obviously it's much better for us to treat people earlier rather than waiting until those diseases develop, and that's when it becomes clear they've got Hep C. So really valuable piece of clinical work for those small number of patients that we may discover that way. And then the other thing that we're asking for is just a screenshot of the sort of data, the numbers of the data in those risk groups, which is what the ODNs and also NHS England are looking at nationally, just to try and get a bit of a picture of where we're at in terms of prevalence and try and work out a little bit more about how many people are out there we think, or how many people might be out there that we think. So the search itself is run just from your own system. It's a really simple search. It can be done by your admin staff. I think in Birmingham, pretty much everybody's on either EMIS or System 1. With EMIS, the search has already been done in the background, and so we can show you where that search data is, and you can screenshot your data, which will give us the anonymized data in the risk groups, and then you can just extract the names of those patients who are coded as hepatitis C positive, and then you can send them to us, and we'll do that cross-referencing work. If you're on System 1, it's not on there already, but it can be done. There's one extra step for practices on System 1 where you need to let us know, and we'll get the search turned on. I don't know if that's the right phrase, but that's what the phrase I've been using. So your system is able to then run the search, which you can then do yourself. Again, the search takes a couple of minutes and provides the data in the same way as the search on EMIS. And then there'll be a little bit of, we'll have a little bit back and forth about what you may want to or be able to do with that cohort of patients. There are, I think, then other things that we could discuss with you. And one of the things that we're quite keen on, which I guess is the next step really over and above finding cases, is looking at the people who might be in the at-risk categories, or certainly maybe looking at people who might be in a number of at-risk categories. And seeing if they wanted to arrange to get tested themselves. And one of the easiest ways of doing this is to give them the information about acquiring a self-test. And so there is a national program now where people can effectively go online and request a test is sent to them. It's sent to their house. They do a little finger prick, dry blood spot test, and send it off, and then those results are picked up. And we think that that's a good way of identifying those people that obviously haven't got a code of Hep C now because no one's diagnosed it, but may be at risk of doing it. And so that's a phase that we're moving towards. I guess if I spoke at the start of the night about where we are, and that's definitely going to be moving towards the latter ends of elimination of the disease, is trying to find people. And so this is, I guess, our first move into that area. There are a couple of other things we could do if you were in a practice or a PCN in an area where there was going to be significant numbers of people that were maybe identified as being at high risk. Then we could certainly talk to you about, for example, arranging a testing event, either at a practice or in the van, in the mobile van, where we could come and say to people, we're going to be there on such and such a date, and you can come and bring your advise your patients to come and get tested themselves. And maybe you could use AccuRx or whatever other texting systems you have, just to let people know about what these tests are and what the risks are. And we can help again with the wording that you might put in those texts if necessary. These are some of those examples of those wording for both those things. So the first one is, this is the link you can click onto. The second one is if we arranged an event where we could do some screening, then we could do that as well. So and again, we can help with all of those things. And I think the final ask we've got of you, hopefully, if you're in a surgery where you've got the TV on the wall, then we can help with some stuff that scrolls through the information giving on those slides, or we can give you posters, and we can give you leaflets to leave around for your patients to pick up. Again, most of those will signpost towards self-testing, so shouldn't provide extra work for you. Over and above, I guess, maybe people asking you questions, and I think we're all in favour of that anyway, in terms of that increased awareness of the disease and of trying to manage things. I think that might be it. This is my email address, and then I'll stop sharing. If you've got any queries about this, then please drop me an email. If you are happy for your practice to run those searches, that would be wonderful. Please drop me an email and I'll get in touch and either give you a bit more detail about the EMIS test, or I'll arrange to turn on the search if you're on a System 1, and again tell you how you can run that simple search, or someone in your practice can run that simple search, and then I can be in touch with you after that search, and we can talk through together what to do with those people that might be identified as having a code of Hep C positiveness. I'm happy to pop out to your practice if you want to and go through those. They'll be relatively small numbers. I mean, to give you a frame of reference, so I was until recently was a partner at a practice. I had two practices, one in Quinton and one in Nechells, and I think about 18,000 patients across our two practices. And we identified across those two practices about 20 people who had a code of Hep C positive at some point, and about 5 of those people, about 15 hepatologists knew about them, they'd been successfully treated, and about 5 or 6, there were things to do. A couple of them needed calling in for bloods. I think one of them was identified as being just an incorrect code, and it was clear from the notes it was, and the other 3 were being called in by the GPs there to look into what was going on, and with a view to arranging screening to see if these were people who may have Hep C, and then obviously if they have, then arranging those referrals. And so that's kind of how the process goes. And I'm obviously happy at any stage down that process to talk you through things. So that's that. Was that a bit quick? It felt a bit quick.
No, that's
No, I
great.
think it
Thank
was
you,
great.
Martin.
Just
And
talking
thank
as a
you,
void. It's a
Jackie.
strange thing to do, isn't it? Just to be like, I'm talking at some slides and hoping people are there. But
No, that's great. Thank you both for the important work you do and for sharing that with us today.
Jackie, is there anything else before we disappear that I've not explained very well? Because obviously you're...
No, I think that's great. I think the only thing that I will add is just in terms of information sharing, we don't, because we're talking, the only patient identifiable data that we're asking for is patients that are already coded as being Hep C positive. And so because this is a notifiable disease, we don't need to have information sharing agreements to do that, because you're sending the names to essentially the treatment team. And for all the other data, we're not asking for patient identifiable data, so it's aggregate only. So just to add that in, but otherwise everything's covered, I believe. So thank you.
Right. Yeah, no, that's an important point, actually. You can absolutely contact hepatology about people on your records from your practice that you've noticed a code of hepatitis C positive. There's no sort of, exactly that.
Okay, so thank
Brilliant.
you.